We are live, by the way. I'm with Jerome Fryer. I'm Brad Goodman. This is Doc Talk Live. We're getting a bit of a late start, so if you are catching us live, we'd appreciate any feedback or comments you have. If you're seeing Doc Talk Live on a rerun, you know, we still appreciate your comments, and sometimes we can actually answer questions post-show, so to speak. Jerome, where are you located, actually?
Canada. So on the West Coast, Vancouver Island.
Oh, nice.
Yeah.
I hear it's beautiful there.
It is. It is beautiful. Yeah. What do we got? Probably, well, I'm talking Celsius, so we got to do the conversion for you guys. But, oh, I don't know, maybe 70 degrees now or something, and overcast. But it's similar to Seattle weather.
So do you, what sports do you partake in? I'm curious.
You think there's a sport that I partake in?
I do. I do. I think
any guesses?
Hockey. What are you showing me there?
I don't know. What am I showing you? I don't know what I'm showing you. No, I don't. You know what? I work a lot, but so I run, swim, and mountain bike. That's okay. What I do now to try to keep my head clear and fresh.
Because you're in the, you know, you're in Canada. You should. That's like the sport to play is hockey.
Yeah. No, for sure. Oh, absolutely. Yeah. And I actually speed skated for 13 years. So then I migrated to hockey about 25 years later. And guess what? In the mornings, I started to develop kind of, right? Because speed skating is just an absolute flexion, right? An absolute flexion sport. So I did that for 13 years, and then I gave it a gap for 20 years, and then I went back to it, and I started playing hockey, and it was like, you know, in the mornings, I was like, I knew what was going on, and I couldn't get out. Like, I was one of those hockey players that would just, you know, I'm like this, right? You gotta learn to be like this, but I was like all about aerodynamics.
Gotcha.
So I couldn't get out of these patterns, these memory patterns of, so anyway, so that's why, you know, I spend most of my time now doing things that aren't the same activity, just to give that bit of a break. I want to reduce the disc height loss over time the best I can moving forward into the next years, right?
I'm in Alabama, but I still play hockey because I grew up in Detroit.
Uh-huh.
So your accent is actually quite familiar to me. So Jerome, you are with Dynamic Disc Designs.
Yes.
I like that DDD, which is the most common back issue, degenerative disc disease. I take it that was deliberate?
That was deliberate, absolutely, because, you know, we see an awful lot of that. And, you know, there's 3D, so I wanted, you know, I was a big fan of Netter, right? Anatomically, I was always very intrigued with anatomy. So yeah, we just came up with DDD, you know. So
show us some models.
Okay, so dynamic, right? So the big thing is that models are static in nature, the ones that we play with. So what I did was you know, it's very difficult to communicate. Like, I'm also a chiropractor by trade.
Okay.
So I do that as well. I've been doing that for 20 years now. But, you know, it's very important to have patients understand their sources of pain. I think, anyways, to explain to them about the procedures that relieve it. So
sure.
When we have these models, they're static. These plastic things that are made in usually China or you know, Germany. The models don't move, and often pain comes on with dynamic movement. So this one is a lumbo-pelvic model. I'll just get right to it. And I create these elastomeric discs with this one in particular has got less stiffness at this level. So when you move this lumbo-pelvic model, now we've got a reduced disc height at 5'1", but this one has reasonably good disc height. But now we can see the micro movements associated with these motions, right? These motions. Yeah. So, you know, when people get out of a chair, for example, you know, the disc height comes down, and then it's a little bit hard to straighten up. Well, very likely we have to think about it as being discogenic, but also you can see how the facets actually there's micro movements in there that can cause symptoms.
So one of my favorite questions, and it's a guess what I'm thinking question, so it's not fair, but I'm just be curious what you think is why is the spine curved as opposed to straight? How come the spine has a lordosis? Show our viewers the lordosis.
So this is lordosis,
right?
We've got a curve. So how do you think this is my, okay, you're posing this question. I'm sure you've thought about this a lot, right?
A lot.
Yeah. So how better would a spine absorb load? Would it absorb load in a straightened position? Or is it better to have a little bit of extension or a little lordosis so you can flex like a leaf spring?
So from a load standpoint, I would say straight. So think about a building. If you were to build a building, would you build a building straight, or would you have a little lordosis to the building?
Building is static.
Exactly. So because the spine moves,
yes,
you need a structure that not only provides stability but mobility.
Exactly. So, right. So that's where the dynamic disc comes from, is now we can actually show how the disc will actually absorb load. Right.
Right.
So, yeah, exactly. Did I pass the test?
You did. You did. You did. Most people want to say that you need something for stability, but the truth is you need something that not only provides stability but allows for motion. Correct. And it's because of that motion that the disc wears out, and the structures wear out. You follow me?
Yeah.
Otherwise, the bone doesn't really wear out. The bone gets soft. You get osteoporosis, but the bone doesn't wear out. It's the motion structures. Like you've got some inflammation around the facet. Show our viewers that.
Yeah. So let me just turn these lights down a little bit bright. Might be better. Let's see here. So, of course, here's a motion segment. All right. Here are the facet joints right back here. All right. So in these models, I've created a hyaline surface. So the articular cartilage is the white. You can see that. All right. Well, I handcraft them all. You can see my initials on there.
Nice.
Yeah.
So you're like a netter. You got your netter.
I'm a wannabe netter.
Yeah.
Yeah.
So a lot of our listeners don't know who Frank Netter is. Yes. But he is the medical illustrator of the 1900s, and he is just a phenomenal artist. And that's what you're doing. You're creating art through these models.
I packed around his atlas, and it was in rags because I just found it fascinating. So I tried to do the same thing in a three-dimensional way. So back to the facet joints, you can see that when the disc height actually loses its, right? So if it loses its height, the facets will actually approximate and they'll slide together, right? Especially when there's instability components. I'll keep coming on camera here, sorry. But you see how those facets will touch and rub and bump into one another? And then eventually, well, this one is kind of interesting. We'll talk about facetogenic pain, but just while I have this one here, you can see that under compressive loads, you see that herniation?
Yes, it comes out.
Yeah. So that's an extrusion that can be actually represented because under load, there's a fissure in here. And the nucleus tracks, the nucleus actually tracks out into that lateral recess. Right?
And that's where that protrusion where you have the disc coming out is where the spinal nerve leaves the spine to go down the leg. I'm just pointing that out to our our listeners and viewers. Yep.
So, right.
So there's the nerve. There's the other nerves. That's right.
All right. There's the nerve there. So as it compresses, sorry, right, it pushes up against this nerve, right here.
Yeah. Can you show us maybe an axial view or not?
Yeah.
Okay.
So here's the cauda equina. So
Correct.
there's the little rootlets, right, that can get compressed in the case of stenosis, right?
And
but
so
here,
that's what I was doing today. I was doing a procedure, Jerome, called Superion. And I don't know if you've got any stenosis models.
Yes, I do.
Okay, perfect.
So you can see here with the facets being, here's the happy facets.
Yeah.
And then over time, they can become arthritic.
Right.
And then with this here, if you look here, there is a projecting osteophyte going right into the IVF. And
right.
there's the nerve there. So when you place this in flexion, you can see it clears up the nerve.
Exactly. I'm not sure people can see my arrow on the screen, but I'm pointing to it with my pointer.
Right. So there's the dorsal root ganglion right in there. And I'm going to take this. So I'm guess your spacer goes in here, right?
Correct.
So let's watch this nerve as you wedge and pull these spinuses apart from one another. See how it releases the nerve?
That's amazing. So
this is foraminal stenosis, but it's also helpful in central stenosis. So central stenosis, this model's crafted, they're all crafted from real human cadaveric specimens. I keep going this way because it's opposite. So I apologize. I keep going off screen. You're here.
Fine. You're fine.
But this one, I start with real cadaveric bone. And then I build the soft tissues accordingly. I have to kind of guess about, like, look at this one, for example. Does this one have lordosis? Right.
No, that one, the model in your right hand has kyphosis.
That's right.
Flexed.
Right. See the end plates?
Yeah. Big difference.
End plate angles?
Yep. So the bottom model, the disc is much plumper, I would describe it.
Right. Yes.
It hasn't developed what we call spondylosis or decreased disc height. Exactly.
So I've dropped the lordotic curve. When I put these two bones together, there's a particular match associated with it. So I crafted a disc that has basically lost all its lordosis. And then I created a thickened ligamentum flavum. And we can look at that here when we talk about central stenosis. So let's take out these nerves.
Okay.
Take out these nerves like this. And now we're looking at a canal that is compromised.
Can you show our viewers a non-compromised canal? Put them up. Can you put them side by side so they can see?
Okay, let's try.
They can see as well. But yes, in your right hand, that canal is way smaller. And in real life, we see that canal, almost down to just a pin drop.
Yes.
So yeah.
Right.
Yep. So that's central canal stenosis. Beautiful.
Central, yeah. And I've tried to create lateral recess stenosis as well. Right. So in flexion, I don't know if you can see this. You can see how it opens. See how much it opens? That
is cool. And that's what we try to do with that Superion procedure.
Yes.
We try to flex. We actually try to block extension more than flex the spine. We try to block the spine from extending backwards.
So when let's squeeze this in extension then. So let's squeeze it in extension.
And it gets small. Yeah. See, it gets a lot smaller.
Yes. So that's what you're blocking. So that makes sense.
Brilliant. And so You know, a new procedure that folks will be seeing in the next 2 to 5 years is relievant. And I believe you've got a model that really helps explain to folks what's going on there.
Yes. So there are multiple pain generators in the spine. We talked facets, talked about discogenic pain a little bit, right? We talked about stenosis, but inside the bone, right inside, if we took a mid-sagittal cut and we cut it right through the midline, we've got a nerve that's deep inside called the basivertebral nerve. And it comes through the Hans venous clefts, which are the clefts on the back here. You can see these little sprues, but they come through, and this is what it looks like. All right, so it comes through the back, and it comes in, and it goes right to the midline, and then it splays up and innervates both the top, the superior end plate, and the inferior end plate. This one has a modic change too. So with modic, there's 3 different categories, and this one's type 1 inflammatory. I tried to create a type 1 inflammatory modic presentation. So yeah, it's a basivertebral nerve.
Yeah, and so what we do is we lesion that nerve, we burn that nerve.
Yes. In
order to alleviate chronic back pain due to what we now classify as vertebrogenic back pain. And the biomarker for that is generally that modic change, which is something you see radiographically.
Yeah. And some people have likened it to a root canal.
Yes, that's a perfect analogy. It's basically a root canal in the back. You're lesioning the nerve, you're destroying the nerve so you don't feel the source of pain.
Yeah. Yeah. Let's
go back to that first model you had, and maybe you could talk a little bit about, you know, motion and SI and
sure,
spine stabilization and the lumbo-pelvic rhythm.
Rhythm. You better take it away.
Well, you were the one who was showing me your tushy.
Okay, I guess you're right. I started it, didn't I?
Yeah.
So there we go. There's dynamic SI joints, right? So we've got the sacroiliac joints and the pubic symphysis on the front here. There's the pelvic ring, right? And you can see that there's movement.
Yeah.
Right? They don't move much, but they move, right?
And they tend to move, I think, in younger females.
Exactly. And this is actually, sorry to interrupt, but this is actually a female pelvis. And you can see here, there is an osteophyte off of the margin of the anterior crest here.
Right.
Very, very likely, this was actually the cadaveric, but very likely there was a hypermobile SI joint. I'm speculating, right? And then there was this reactive bony remodeling to try and stabilize it. So it's really interesting that when we get these, you can see the pelvic ring here, you know, let's see here.
That's what I would call the birth canal.
Yeah, and it's perfect, you know, it's round for what reason? For a head.
Right. Yeah, makes sense.
Mm-hmm. Yeah. So, yeah, as we move up, so yeah, that's why I created a little bit of inflammatory aspect associated with the SI joint here. And as we move up, like I said, I've created a hypermobile 4 or 5. So common is to get these biomechanical faults and, you know, these little mechanical triggers, these insults, repeated insults that people don't understand when they get out of a chair. Oh, right. There's this micro movements that are causing these repeated insults to these facet joints or other structures. So, you know, under flexion and extension, right? And if we want to look a little bit closer, here's a 3-level model, right? And, you know, can we see the problem? Do we know where the problem is with this one? It's like trying to look at a static MRI. Sometimes it's not too revealing, but let's maybe do a flexion extension view, right? Now you can see that middle disc actually is also hypermobile, right? So you get these little buckling, they're called buckling moments, where the facets.
So speak a little bit more about that hypermobile middle disc, because, you know, we get a lot of, let's say, dynamic x-rays where we flex and extend. And what we look for is really, I would say, more listhesis or slippage.
Right. So you can get that. You can get a little bit of listhesis. Right. There's a retro.
Right.
Right. You're right. Those subtle listhesis. But I think also importantly is look at the posterior vertebral line. Right. So the posterior vertebral, you see there's a bit of a break in it.
Yes. That Z joint has more flexion to it than the other levels.
Yes. Yeah. So those subtle changes, you can see that talking about the lordosis there, right? There's lordosis. See, the lordosis disappears at that one particular level.
So because we'll call this, let's say, the L3-4 facet, because the L3-4 facet is hypermobile, do you think that would be more likely to be a pain generator?
I would say probable, right? Probable. You know, one of the things that I do is my practice is I will push posterior to anterior when they're laying prone, and I'll just do a simple evaluation. Is that sore? And they'll say, no, not really. And then as you get closer, right, you can see the segments, they're moving a little bit more. So I would say probable.
As a chiropractor, you being a chiropractor, I would think it would be easier for you to address a hypomobile area.
Yeah, exactly.
Opposed to a hypermobile area. How would you deal with somebody who's hypermobile?
Exactly. So these motions, these stiffnesses have to be all relative, right? So if this one's hyper, it makes no sense to try and make this thing move more. Likely what's best is to try and make this move more. So then this guy is not moving as much.
So you want to address the segment below it.
Yeah, the best we can. Sometimes it's a bit tricky, right? It's a bit tricky sometimes because often when you go to create a bit of a rotational torque, whatever, maybe this one here actually has an audible release feature. Being a chiropractor, it actually snaps, right?
How are you creating that sound?
I've created a little bit of like a simulated synovial fold in there.
So when a chiropractor manipulates a patient and there is an audible pop.
Yes.
What is that? If I were to pop my knuckles?
Yes.
You hear it?
Yeah. Oh yeah.
What is creating that noise? Is it release of gas or is it something else?
Releasing gas we know happens. See, I'm also, I've got a couple papers published in this field. And I don't know if you saw, there was a paper published in PLOS 1 in 2015, but I was a subject. I volunteered myself as a subject too, put my finger in an MRI and we pulled and we watched it. Yeah, that was my finger.
And so tell us what was.
So what we saw, because we were basically exploring, no one had done this before, and we only had frame rates of 3 frames per second. And the previous theories were that there was a collapsing bubble, a cavitation. So an inception of a cavity, a gas, and then it collapsed. And it was that collapse that actually caused the sound. This is that erosive cavitation process, right? So when we did the study, we saw a cavity formation and it didn't disappear. So it was related to a cavity formation. So since then, I've developed an in vitro model, and we're looking at right now at time frames that are at 5,000 frames per second. And the preliminary data right now shows that the sound comes before the inception of the cavity. So it looks like it's something else. And the the gas is just a byproduct of the event.
You know, I've been manipulated before. I do sometimes like the sensation of that. Yes. But it's like I almost want to hear the pop. I mean, it doesn't really have to pop to work, but tell us about the pop. I think the pop adds something to it. Well, the pop indicates that there's successful separation of the articular surfaces. Right? I don't know if you can see, but my finger here, right? If you look, you pull on my finger, right? And there's a certain distraction, but as soon as it pops, now there's laxity. You see there's laxity there? Right. So you've got increased laxity. So of course the sound is like, but there's also, I think it releases there's intrinsic compression within a synovial joint to kind of hold the two articular surfaces together. And it's really interesting, but what I've done in this study is I've taken simulated synovial fluid and I've degassed it. So it's a pure synovial fluid. So it's pure without any bubbles in it. And it has an intrinsic ability to kind of hold with regards to like adhesion. So it creates a stability aspect associated with the joint too. But when you release it, like say if those two surfaces are sensitive, if you pull them apart, there's like a relief if there's pain generators in the subchondral bone or something else within. There's a release and then there's decreased tension within the joint. But it takes about 35 minutes before this whole surface kind of goes and sucks back together again, called the refractory period. That's why I can't do it again, right? Because I need a certain amount of time for the little pump systems to kind of push out that gas, those bubbles, and then it creates a seal again. So that's why it's often you get that temporary kind of, that feels much better, but then it kind of, there's an aspect of symptoms kind of coming back sometimes. So one of the things I worry about, what you're trying to do really when you manipulate the spine is to distract those facets. Right, yes, yes. But in order to distract it, yes, you're generally introducing a degree of rotation. Yes, it has to be in the lumbar spine just because of the way they're oriented, the facet joints are oriented. So when you create that rotation, sometimes I worry you're going to actually cause a tear to the disc. Yeah, I'm always concerned too. So how do you, is that the art? Well, first of all, because the fibers are oriented, you've got the disc, you got fibers this way, and you got fibers going this way, right? So if basically in setup, so I'd go and set up first and I'd ask and I'd gently put some forces in. I said, is that sensitive? To get a sense of, first of all, history kind of gives you a smell of whether things are really active in there, right? If they're active, you're like, you got to just kind of really play it easy. But there's also setup. So you got to set up and like check the vector. Is that sensitive? And if somebody says it's sore, well, it's kind of, you don't want to push through that. You got to keep in mind of any radicular type of stuff or, so you got to go in cautiously, of course, right? So here's a question from a listener, which this listener is actually this is a very astute question. Oh. It says, can you discuss briefly cervical manipulation in the incidence of carotid artery dissection? Yes, big topic. Am I qualified to talk on that? Probably not. Well, I mean, if you're a chiropractor and you've manipulated necks, then you must be concerned about that. That's the one sort of area that would be challenging. That's what you want to avoid. Yes, absolutely. Absolutely. That's not my, I don't jump on cervical manipulation right out of the gates, right? That's kind of, to me, I try many other strategies before I employ that. And then often what I'll find is that I can resolve the symptoms without doing that force. Do you have a cervical model? Yes.
Absolutely.
And show everybody the vertebral artery.
Well, I don't have a vertebral artery with me.
How about the canal where the vertebral
I'll show you
artery
the canal. So the canal is right. You can see the holes here on this. If you can see.
Can you put like a pin through it or a pencil so they can?
So there's one there, and it goes all the way through. So there we go. So you see, all in reverse here. This is challenging my dexterity.
Yeah. You got it. You're pointing to it.
So there we go. There's that, and then you can see, and it goes all the way up.
So generally, when the head is extended,
yes,
and rotated, that's what puts the vertebral artery at risk.
We think in some cases, yes. Right? It takes a bit of a torturous turn at the top here too, right?
Exactly.
So it takes a bit of a turn at the top.
And so the concern, David, is that with the head extended and rotated, you can torque the artery and it can tear and lead to dissection.
That's, I think hasn't been shown definitively, but we have to be cautious, and we have to continue doing science, and we have to be mindful on cases that are coming in that may be in the process of already having an injurious artery. Like it's an area that we got to continue to focus on doing research on. Of course, patient safety is priority number one, right?
So I think I haven't seen a compression fracture yet. Do you have a model of a compression fracture?
No.
Okay.
No.
Have we seen have we missed any models yet?
No, I think you've got most of them. I've got many more. I don't have them all with me, right?
Okay.
Here's the cervical. Here's the cervical, and you can see right? That's where the vertebral artery goes through. Right, you can see the canals there. This one has the ALL and the PLL on the back.
That's the ligaments, the anterior longitudinal ligament and the posterior longitudinal ligament. The disc in the neck is different than the disc in the low back. Do you have any comment on that? I mean, anatomically, they're kind of different. They don't, you know.
Yeah, they are different. They're different. Like there's the vertebral joints, there's it kind of comes up, the bone kind of comes up and kind of scoops a little bit more. The annular fibers aren't that 30-60 that I was talking about. They're more in a vertical orientation. It's pretty heavy posterior longitudinal ligament up in that region too. It's a little different animal up there for sure, right? Are you a big, so do you believe, here's a question for you. Someone comes in, presents with pain, let's say in here, and it more painful kind of an extension, right? And it's a bit sore deflection. What's your first what's on your differential? Are you more of a discogenic pain origin kind of a guy, or are you more of a facetogenic pain, or does it really depend?
No, I will answer that question. So in the neck, I tend to, when we're talking about axial pain, meaning we're talking about pure neck pain or pure back pain without neurologic symptoms down the arm or leg. When we're talking about axial pain in the neck, my dogma, my belief, as you called it, tends to be more facetogenic.
Yeah, okay. Yeah.
And also, I'm not a big, what I'll call a myofascial type of person. I believe myofascial pain is an epiphenomenon. It's a referral from in the case of the neck, the facet joint or the zygapophyseal joint, whatever your nomenclature is. In the low back, I tend to gravitate more to the disc.
Yeah.
So in the neck, I think facet. In the low back, I think disc.
Yeah.
That's my bias. Okay.
That's mine too.
Okay.
Yeah. Yeah.
Well, I've enjoyed talking to you, Jerome. I like your models. They're brilliant designs. I like the fact that you're a big netter fan. I want to see your drawings next.
Oh, no. That's probably why I can't draw. No.
You work with clay at all? I do some pottery. Do you do pottery?
Yeah, when it comes to sculpting, for sure, right? You know, yeah, for sure. You know, sculpting that latest Kata Quina was very interesting. But, you know, I have my micrometer out. I've got all the literature out. I'm checking, you know, dimensions. And
there's a guy in Europe who makes models. Like they're real bones. He calls them saw bones or whatever, but he creates tissue around them so that you can use them under fluoroscopy and put needles in and practice needle procedures under x-ray without having to get an actual cadaver.
Yes, our models are radiopaque. So I've had mine filmed, but yeah, it shows up, right? Yeah.
Just before I let you go, so Sam says, good to know about the disc versus facet in backs versus necks. But I assume there's no question there, Sam. But if you do, you got a few seconds to type it in. But yeah, so in the neck, I tend to think facet, and in the lumbar spine, I tend to think disc. Now, as people age, you know, in the elderly population in the low back, I tend to go back to the facet. And I feel like facetogenic pain is more prevalent as we age in the lumbar spine. But I think that the 20-year-old to 50-year-old population, I think the disc is a more common source of pain in the lumbar spine.
Yeah.
Thanks, Jerome. I appreciate it.
It was wonderful. Thanks for having me. I really appreciate it.
Take care.
Bye.
Bye. Okay. I've stopped it. No, I don't know. Maybe it might still be running.